Welcome. In this video, I'm going to introduce you to a rogues gallery of wide complex tachycardias and how to differentiate them. Most of this video will focus on rules for differentiating VTach from aberrant supraventricular rhythms. Think narrow complex tachycardias with a bundle branch block. But we will also be looking at some polymorphic rhythms and reiterating the principle that when it's really wide, think sodium channel blockade or hyper K. Here's a reminder of a fundamental management principle for tachycardias. You can always shock, but you need to have a plan if that fails. Here's a chart breaking down monomorphic, that is, 1 QRS shape, wide complex tachycardias based on rate, regularity, and p-wave relationships. The one breaking down polymorphic wide complex tachycardias is on the right, broken down by rate, how the QRS is actually polymorphic, and some clinical associations. This is on your sheet. Let's start with monomorphic wide complex tachycardias and try to make distinguishing between them a bit more memorable. Regular wide complex tachycardia, the good, the bad, and the ugly. The first R-rated movie I ever saw. Clint Eastwood wasn't exactly good, and neither is AFib with aberrancy, but it's usually better than Lee Van Cleef in VTach. Then we have the ugly. Either of the first two with the addition of hyper K or sodium channel blockade, resulting in a wide or ugly QRS. I'm going to introduce a mnemonic here that will give you 8 things to look for when dealing with the question of the bad, VTach, versus the good, not VTach. I'm not a mnemonic fan, but distinguishing VTach from SVT with aberrancy can be tough, and it helps to be systematic. If any of these are positive, it makes VT the presumptive working diagnosis. But keep in mind, if the QRS complex is super wide, start thinking about sodium channel blockade and hyperkalemia on top of VTach. The fundamental concept in identifying VTach, if there is one, I would say is delayed ventricular activation. We'll see this in 2 of the rules that we're about to go over. First, though, let's discuss clinical context. If you're older and have a history of MI or structural heart disease, you're much more likely to be in VTach, like 90% more likely. But think about risk factors for hyperkalemia and sodium channel blockade too. Are you a dialysis patient who missed it? Is this an overdose patient? Is this person on flecainide? And then, if you're dealing with someone who has a very similar morphology to a prior ECG, or you're dealing with a kid, this might point towards SVT with aberrancy or another non-VTach source of wide complex tachycardia. Now for the rules. We'll start with axis. Extreme axis deviation is relatively specific for VTach, with the only issue being some people have this at baseline. Find an old EKG if you can. It's also good to keep in mind that a flipped axis in the setting of a bundle branch block suggests VTach. If you see a left bundle with a right axis deviation, or a right bundle with a left axis deviation, also suspect VTach. Lead AVR provides a great shortcut for identifying VTach. It is specific but not particularly sensitive. If AVR is entirely positive, it means that the impulse must be traveling from the apex of the ventricle superiorly. You can look at the illustration on the bottom left. It gives you the viewpoint of AVR looking down the barrel of the left ventricle. If AVR is a large upright R wave, it means that the wavefront is coming at you from the ventricle and that you're therefore dealing with VTach, presumptively. However, if it's super wide, it could also be flecainide toxicity or hyper K. The Brugada rule is that a delayed R onset to S nadir, that is over 0.1 seconds, in any precordial lead is highly suggestive of VTach. As we discussed, an important concept in identifying VTAC is that depolarization happens more slowly, and the Brugada rule quantifies this concept. Now for bizarre versus bundle. Most wide complex tachycardias we see will have right or left bundle morphology in the precordial leads. The less consistent the morphology is with a recognizable bundle shape, the more likely it is to be associated with VTAC. Let's also keep QRS width in mind here as well. VTAC comes in many forms, and some are more dangerous than others. The less dangerous forms will be narrower and more bundle branch-like in appearance. Once we're starting to get wider though, over a QRS of 160, we're much more likely to be dealing with VTAC. And by the time we're over 200 milliseconds, to say it again, we need to start thinking about hyper-K or sodium channel block. Now for concordance. If you have a dominant R wave in all precordial leads or a dominant S wave in all precordial leads, then you have concordance, and this is specific for a ventricular rhythm. Now for capture. Presence of capture or fusion beats is specific for VTAC. A capture beat is a narrow QRS sinus-appearing beat occurring amidst a run of VTAC beats. A fusion beat is a narrower beat than a VTAC beat, but wider than a sinus beat. Like some beats in AFib with WPW, it reflects both His Purkinje and cell-to-cell activation, hence fusion. The delay rule quantifies a central concept in VTAC identification, as I mentioned before. I'm asking you to remember R wave peak time over 50 milliseconds, or extending over one small box. The best lead to look for this is in lead 2. The physiologic basis of the concept is that in VTAC, cell-to-cell transmission, rather than His Purkinje signal transmission, results in a slower upstroke or downstroke of the QRS complex. Finally, dissociation. Just like with complete heart block, if we can identify that the P waves and the QRS complexes aren't related to each other, then we've presumptively identified VTAC. If you can't identify hidden P waves easily, you can put on some Lewis leads or give some adenosine. Now for polymorphic wide complex tachycardia, the shapeshifters. Recognition for the shapeshifters is a different matter. ECG interpretation can be seen as a spectrum between pattern recognition and logical reasoning. There are some rules for these tachycardias, but there's a lot of you know it when you see it with polymorphic or irregular wide complex tachycardia. There's also a good bit of clinical context involved in figuring out what's going on, especially if your patient is dealing with the dreaded T1000. First in our rogues gallery of polymorphic wide complex tachycardias, we have pre-excited AFib, better known as AFib with WPW, aka the Wolfman. The characteristic look is some stretched looking QRSs, that is stretched in terms of width. It's very fast, at least one RR less than 250 milliseconds, that is 1.5 big boxes, is a rule we can apply for identifying this. The safe tools include electricity and class 1C antiarrhythmics like procainamide and abutolide. What you don't want to do here is slow down the AV node because you don't want the atrial signals to get increasingly conducted by the accessory pathway. Unlike the AV node, accessory pathways don't have a speed limit, so this could result in extreme ventricular rates that could degenerate into VFib. Now for polymorphic VTAC in torsades. The note on terminology is that torsades refers to this rhythm in association with long QT. With ischemia, which is the other common place you'll see this rhythm, we just call it polymorphic VTAC. The terminology doesn't matter so much. In terms of recognition, you'll notice that the variation is more in QRS height rather than width. We call this changing axis. It's also associated with channelopathy sometime, but the big ones to think about are things that would prolong someone to a prolonged QT versus ischemia in terms of the cause that we would be treating if we saw this rhythm. In general, it's safe to use electricity, lidocaine because it does not prolong the QT, and magnesium. I couldn't resist including bidirectional VTAC here. It's rare. You're not going to see it very often. It's associated most classically with digoxin, which we're seeing less frequently on an outpatient basis. It's also associated with channelopathy, most famously catecholaminergic polymorphic VTAC, but also Brugada, and it can also be associated with hypokalemia. As always, it's safe to shock. Clinical context should guide you on the route you should take for treating this rhythm. So here are some concluding thoughts regarding wide complex tachycardia. Remember that the older and more comorbid someone is, the more likely it's VTAC. When you see a wide complex tachycardia, you should be thinking VTAC until proven or highly suggested otherwise. The essence of the VTAC rules is that the initial QRS upstroke or downslope is slow. Remember, as always, the wider the QRS, especially once you're getting over 200, the more likely we're dealing with hyper-K or sodium channel blockade. Turning to polymorphic rhythms, the faster it is irregular with variable QRS width, the more likely it's AFib with aberrancy or AFib with WPW. On the other hand, if you have a very fast rhythm with a variable QRS height more than width, in other words,